The human body has several different gas spaces. The lungs are the most obvious of these, but you also have assorted sinus passages, the middle ears, and gastrointestinal system as well. In addition, other gas spaces are introduced when we go diving. The main one of these being inside our mask. Each of these gas spaces must be equalized to the surrounding pressure as we dive. This equalization process happens mostly without us noticing, as in the case of the lungs, where it happens by normal breathing. Or we are taught to manually equalize them to surrounding pressure by using various techniques, as in the case of the middle ear spaces. Many of these were discussed in the Dive Medicine for Divers section on diving fitness. When we're unable to equalize these gas spaces, the potential for barotrauma exists. Barotrauma literally means pressure injury. It is an injury to the body caused by pressure differences, which can also affect the volumes of gas spaces mentioned in accordance with Boyle's law. In this section, we will review the various types of barotrauma divers can and do encounter on a regular basis. One of the most serious types of barotrauma involves the lungs. Assuming the lungs and the diver are healthy and the diver is fit for the dive, this situation is fortunately relatively easy to avoid. As part of their initial training, divers are universally taught to breathe continuously and never hold their breath underwater. This is considered to be the golden rule in diving. Many divers do not understand the reason for this rule, however. Divers are able to dive because the scuba regulator delivers breathing gas at ambient pressure. That means the air coming out of the scuba regulator is at the same pressure as the water surrounding the diver's body. When divers ascend, the surrounding pressure is reduced and the breathing gas in their lungs expands. From a depth of 33 feet, 10 meters of seawater, that breathing gas will double in size. As that gas expands, if you don't let it out by exhaling, it has to go somewhere. In that case, it will most likely tear the lung tissue. This is called lung barotrauma and can sometimes be noticed by coughing up pink or blood-stained sputum. But there may not necessarily be other complications. Whenever a diver is suspected of suffering lung barotrauma, the person should refrain from diving unless seen by a physician experienced in dive medicine and proper tests have been done. Always expect lung barotrauma if a diver had a rapid ascent and is coughing pinkish sputum, with or without chest pain. Lung barotrauma can also be associated with a number of complications, and one of those is gas released into the chest cavity.
All right, well maybe this oxygen will help.
Gas leaking into the chest cavity can cause a number of conditions, known collectively as lung overexpansion injuries. These injuries include a collapse of the lung, known as a pneumothorax, gas in the area around the heart, known as mediastinal emphysema, and gas tracking upwards out of the chest in the tissue layers, known as subcutaneous emphysema. To understand how lung barotrauma happens, you have to understand the basic physiology of the lungs themselves. Your chest cavity has two linings called pleurae, the outer pleura being attached to the chest wall and the inner pleura being attached to the lungs. The outer and inner pleura are not actually joined, but are kept together by a negative pressure between them. Moisture between the pleurae prevents damage from the two rubbing against each other. So when the outer pleura expands and contracts, the inner pleura moves with it. When you inhale, your diaphragm, situated below your lungs, moves down. Also, the rib muscles move out. These two movements expand the chest, and therefore the lungs, pulling more air into them. When the gas inside the lungs expands as the pressure decreases during ascent, in accordance with Boyle's law, the expanding gas can lead to the lung tearing, and the gas then escapes from the lungs and is now inside the chest cavity itself, between the pleurae. This situation causes the lung to collapse as the negative pressure inside your chest cavity has changed. This condition is called a pneumothorax. A pneumothorax is a medical emergency as the collapsed lung is not functional. If more gas leaks into the chest cavity, or if the gas expands further, like during an ascent, the pressure in the chest can increase to such an extent that it also compresses the other lung. This situation is called a tension pneumothorax and is deadly within minutes, as the increased pressure in the chest prevents blood from returning to the heart. A pneumothorax does not require recompression treatment in a chamber, but it will require a person with appropriate training to insert a needle or chest tube to drain the air that is inside the chest cavity so that the collapsed lung is reinflated. A person would, however, need recompression therapy if this is associated with a gas embolism or decompression sickness, but the gas must still be drained before the person can be put in the chamber. Because a pneumothorax prevents a lung from working normally, a person must compensate for this loss of function in other ways. One of the first things you may notice is that the diver is breathing faster than normal to increase the ventilation through the lung that is not collapsed. Chest tightness and pain normally causes the person to breathe shallowly, and if ventilation is not adequate, the increase in carbon dioxide and lack of oxygen will cause a bluish discoloration of the lips and later the tongue. Not all of these have to be present. A diver can be suffering from a pneumothorax with only one of these signs present and later deteriorate to a possible life-threatening tension pneumothorax as more air leaks out. Fortunately, such deterioration does not always result. If a tension pneumothorax is present, most, if not all, of these signs will be present. In such a case, you will also notice that the diver's windpipe will appear to have shifted to one side as a result of being pushed by the high pressure in the one side of the chest, now also starting to compress the other lung. When a diver surfaces rapidly, like during an emergency ascent, the accidental inflation of a buoyancy compensator, or in any similar situation, it's important for you to be able to recognize a pneumothorax as a possible life-threatening complication of barotrauma of the lungs.
Well, I'm just going to take your temperature.
To recognize a pneumothorax, you must look for the signs as described and also use a stethoscope. With the stethoscope, you will hear breath sounds on one side of the chest, but not on the side of the collapsed lung. The chest movement may also be diminished on the affected side. The second common complication of lung barotrauma is mediastinal emphysema. In this instance, the air from the lung escapes into the middle of the chest, rather than to the spaces around the lungs, putting pressure on the heart. This can reduce the effective filling of the heart with blood. Because the removal of carbon dioxide and supply of oxygen via the blood can be impaired, the body responds by increasing the breathing rate. The pressure is not usually enough to be life-threatening unless a pneumothorax is also present. This diver may feel faint, complain of chest pain or tightness from the diaphragm to the neck, and may be short of breath. You may sometimes also notice a change in the diver's voice. The voice is commonly described as brassy sounding. Typically, this condition will not require medical intervention unless severe. Breathing as close to 100% oxygen as possible will aid the diver's body in reabsorbing the escaped gas. Always examine the diver for the presence of a pneumothorax as described. Recompression therapy is not indicated unless there are signs of a gas embolism or decompression illness. The diver should still be examined by a physician, particularly to assess fitness to return to diving. A third complication of lung barotrauma is known as subcutaneous emphysema. This means the gas has escaped from the lungs, tracked up in the tissues along the windpipe, and is now underneath the skin in the chest and neck. You can usually identify this condition with a feeling of fullness around the throat, a change in voice, and difficulty swallowing. You may feel the gas in the tissues around the base of the throat on palpation. Sometimes you will hear a crackling sound, crepitus, when you touch the affected area. This is not normally an emergency unless signs of a pneumothorax or arterial gas embolism are present. The diver should breathe oxygen and be examined by a physician. A diver with any of these lung barotraumas should not return to diving until he is evaluated by a physician familiar with diving medicine and appropriate tests have been conducted. Lung overexpansion injuries do not automatically cause gas bubbles to enter into the arterial blood supply, but it is a possibility. When it does happen, however, it is one of the most serious complications of lung barotrauma. Arterial gas embolism can occur when part of the lungs, for instance an alveolus or bronchiole that is adjacent to a blood vessel, tears and allows the breathing gas to enter the bloodstream. When signs of lung barotrauma or any of the lung barotrauma complications described earlier are present, you should anticipate a possible arterial gas embolism and monitor the injured diver for any neurological signs. If neurological signs are present, the diver will need recompression therapy.
I look forward to this thing for a long time, then I thought, oh my gosh, what is
There are
it?
many theories about the purpose of the sinus cavities in the head, ranging from humidifying the air we breathe to aiding balance to reducing the weight of the human skull. Regardless of the reason for these air passages, we are stuck with them, and they have to work properly or we can't dive. There are 4 pairs of sinuses. They are arranged around the nasal cavity. Above is the frontal sinus. Beside it is the ethmoid sinus. Behind it is the sphenoid sinus. And below it is the maxillary or cheekbone sinus. Each of these sinuses is lined with specialized mucous membranes with hair-like projections called cilia. These miniature hairs, similar to those in our airways, sweep mucus towards the openings to the nasal cavity, where it is transported towards the back of the throat and swallowed. If these cilia cannot remove the mucus, the sinuses become blocked and can become infected, called an acute sinusitis. Some persons have long-standing problems with their sinuses, with infection present for longer periods, and are thus suffering from chronic sinusitis. When a sinus cavity is blocked, it cannot be equalized properly. Normally, sinus passages equalize on their own, or when we equalize our middle ears. When we cannot equalize our sinuses, we feel pain very quickly, as the sinus cavities are completely incompressible. When the middle ear hasn't been equalized to the ambient pressure, the eardrum can bulge in or out to some extent to accommodate slight pressure and volume changes. The sinuses do not have a movable wall, so you will feel the pain immediately as the pressure changes. Swelling and bleeding in the mucous lining will happen almost immediately, even at shallow depths, as blood is forced into the area in an attempt to equalize the pressure inside the cavity. Your frontal sinuses are the most commonly affected. The air passageway to these sinuses is thin and winding. You'll notice this pain above and behind the eyes. With a partial blockage, you may hear a squealing sound as air moves up to equalize this space. The second most common sinus problem appears in the maxillary sinus. It may feel as if you suddenly have a toothache when this sinus is being squeezed. If your sinuses do not equalize on their own, you should never force them. The maxillary sinus lies just under the eye, and the extreme pressures of diving, may even cause an implosive injury with a fracture of the bony plate dividing the sinus and the eye. Barotrauma may also complicate the underlying sinusitis and cause severe infection and even meningitis. If infective material is forced into the brain cavity, it can cause a brain abscess. Never dive with acute sinusitis. It is wise to see a physician with knowledge of diving medicine to assess fitness for diving. A common sign of sinus barotrauma is bleeding into the mouth and/or nose, and this is often seen after the dive. However, occasionally blood can be seen in the mask during the dive. This blood appears to be green in color underwater. Sometimes, decay underneath a filling or air entering and becoming trapped in a space within a tooth can create a gas space that can cause trouble while diving. If this air cannot escape and expands during ascent, it can put pressure on the tooth and underlying nerves and cause pain. This is known as dental barotrauma. In an extreme case, a filling can be dislodged or a tooth can explode. Sinus barotraumas can sometimes cause pain in the teeth that is mistakenly thought to be dental barotrauma. Some tooth abscesses cause the formation of gas. As this gas is subject to Boyle's law, the infective material may be forced into the tissues of the jaw and cause a severe infection of the jaw and face. It is wise to see a dentist regularly to ensure that diving is safe for you, especially if you have a number of fillings or other dental problems. Gases are produced in our digestive system, and unless these can escape during an ascent from a dive, they expand and can cause pain or discomfort. Eating or drinking gassy substances too soon prior to diving can precipitate this. It can also occur when a diver is nervous and gulps air into his or her stomach. Usually, excess gas can be vented in the usual ways, and the discomfort or pain is quickly relieved. Divers who had a hiatal hernia repaired are sometimes not able to burp. This may lead to problems during a dive as gases in the stomach expand. Some divers use a swallowing technique when equalizing their middle ears. If they swallow the breathing gas, it may cause problems during the ascent. Learning a new equalizing technique would obviously resolve this dilemma. As mentioned earlier, there are also man-made air spaces that can cause barotrauma. These include masks, hoods, and earplugs. Your mask is a man-made airspace. In fact, the air in your mask is what allows your eyes to work properly in the water and allows you to see. If you fail to equalize that airspace while diving, though, the effects can be dramatic and painful, although not life-threatening. Failure to equalize your mask can cause bruising around the face and eyes as the blood vessels in those tissues swell with blood and even burst. It can look extremely dramatic. By simply exhaling into your mask through your nose periodically, you can alleviate this potential problem. Many divers learn to do this unconsciously or do it when they clear water from their mask. It's a small airspace and doesn't take much pressure to equalize relative to the size of your lungs. Simply exhaling through your nose will solve any potential problems. Tight-fitting hoods can create an airspace as well. The hood material can seal off the external ear. If this seal is strong enough to keep water out completely, it can create an airspace that is not equalized. This can cause problems when you attempt to equalize the middle ear, as the pressure on the outside of the ear will prevent the eardrum from moving properly. It's a good idea to let small amounts of water inside your hood when you begin a dive. Allowing water to enter your outer ears will save you problems later. Earplugs placed in the outer ears are a potentially serious problem for divers. Just like with tight-fitting hoods, they create an airspace on the outside of the ear that you cannot equalize. Unwary divers will mistakenly wear earplugs from time to time, believing they can use them to keep water out of their ears, or will attempt to dive with earplugs when they have had a traumatic injury to their eardrums. In short, Divers should never wear earplugs to keep water from their outer ears. If for some reason you cannot expose your outer ear and eardrum to water, you should not dive. Earplugs can cause severe bruising and trauma to the very sensitive outer ear canal. It can also effectively splint the eardrum in place, making it impossible to equalize. This can cause trauma to the middle ear, as pressure is not equalized on descent or ascent. There are vented earplugs that allow the pressure change on the outer ear to happen more slowly, and these are probably all right for divers to use. They're useful when divers have trouble equalizing. However, they should not be used to protect the outer or middle ear from water. If your eardrum is not intact, you cannot use vented earplugs to dive. The vent still allows water into the outer ear and against the eardrum, just more slowly. A common mistake beginning dry suit divers make when they use a suit is to forget to equalize the air in their suit on descent. This can lead to a barotrauma on localized portions of the body. When diving a dry suit, typically you will control your buoyancy underwater using the suit itself. As you add small amounts of air into the suit, you will avoid compressing the suit to the point that it causes painful bruising along the body. Many dry suit divers will only use their BCDs to establish positive buoyancy on the surface and use the suit itself for underwater control.